Positioning for Portables and Trauma by Brandy Jones. What is trauma? Trauma, a sudden, unexpected event, can be dramatic, violent, forceful, blunt, penetrating, or explosive. As you can see, there's several definitions here. Trauma affects all people in all age ranges. You must be prepared for a variety of procedures on all age groups. These injuries are just to name a few. What kinds of trauma? Gunshot wounds, stabbings, motor vehicle collision, MVC, a motorcycle collision, MCC, head struck, an acute head trauma, traumatic brain injury, falls from a ladder or one-story building or three or so on, falls from a bed or shower, suicide, drowning, industrial work-related injuries, crush-related injuries, electric shock injuries, gas exposures, mass casualty. Trauma center. The term trauma center signifies a specific level of emergency medical care. This is defined by the American College of Surgeons Commission on Trauma. Level 1. Most comprehensive. Usually a university-based center and/or research facility. A large medical center, complete imaging capabilities, and specialty physicians on site 24 hours a day. Level 2. Same as Level 1, except not a research facility. May not have as many specialists. Level 3. No specialist can stabilize patients for transport to a higher level center. May not have 24-hour imaging. Level 4. Clinics attend minor injuries, some stabilization before transfer. Maryland and surrounding centers. This is not in your books anywhere. Primary Adult Resource Center. The most #1 place to go for adults would be University of Maryland Shock Trauma Center. Level 1, Johns Hopkins Adult Trauma Center. Level 2, Johns Hopkins Bayview Medical Center, Sinai Hospital, Prince George's Hospital Center, Suburban Hospitals in Bethesda. Level 3, Meritus Medical Center in Hagerstown, Peninsula Regional Medical Center in Salisbury, Western Maryland Regional Medical Center in Cumberland. Out-of-state centers, Christiana Care Health System in Wilmington, Delaware, MedStar Washington Hospital Center in D.C. For pediatrics, the Level 1 place to go to is Johns Hopkins Children's Center. And then the other Level 1 would be Children's National Medical Center in Washington, D.C. Introduction to trauma. Situations frequently arise in which the radiologic technologist encounters patients that have had some type of trauma. This will require adaptations in positioning and care. This may mean that patients cannot be brought to the radiology department for their exam. Instead, a mobile, portable X-ray unit must be taken to the emergency room or trauma unit. Some trauma units even have X-ray tube on a track in the ceiling, similar to a normal X-ray room, but you will still use skills in placing the IR. Even if the patients are brought to the radiology department, they may be immobilized in a number of ways. Intro continued. Patients may be wearing an e-collar and placed on a backboard. Patients may have one or more splints indicating a possible limb fractures or dislocations. Often, all projections must be obtained with the patient in supine position. In these cases, adaptations of the CR and the IR placement may be required. This requires the use of stationary grids for cross-table laterals and other adaptations. Positioning principles. 3 principles to keep in mind while you are performing mobile trauma radiography. 1. You must obtain 2 projections 90 degrees from each other. Must have a true central ray to part to image receptor alignment. 2. The entire structure must be included. 3. Maintain safety of the patient, healthcare workers, and the public around you. Ultimately, you want to provide a perfect image just like your normal walkie-talkie patient. An excellent quality image with all the required anatomy included. All positioning rules still apply, however, you may need to think outside the box, and you may need to improvise to get these perfect images. It is imperative not to aggravate the patient's condition when you are trying to obtain these radiographs. Slide the IR gently underneath the patient. This can be done skillfully and swiftly. Move your tube and IR whenever possible and not the patient. Principle 1. Two projections 90 degrees to each other with the true CR part to IR. The examples are shown below with this foot X-ray. Only as a last resort should one projection be taken. If all else fails, do an oblique to replace an AP or an lateral. Principle 2. Entire structure or trauma area of IR. AP and lateral, distal leg and ankle. Principle 3. Maintain the safety of the patient, healthcare worker, and the public. When radiographing a patient with a portable, be sure that the equipment that you move is not connected to the patient. Side rails may have to be lowered to place cassettes. Do this as quickly as possible. Don't ever assume that the patient is unable to move. After imaging the patient, place everything around the patient's bed in the room in the way you found it when you came in. When shooting an X-ray, announce that you will be exposing by saying X-ray. Give the staff enough time to step back prior to the exposure. Other practice standards. Always use PPE, personal protective equipment. In trauma, gloves, gowns, and booties are pretty standard. Now, with COVID-19, additional precautions have been put in place to take measures to protect yourself. Wear all proper PPE required by the facility you are at. This usually includes a N95 face mask, a face shield, gowns, gloves. Some places and some people just prefer to add booties and a cap. Include both joints on upper and lower limbs of long bones. Possibly secondary fractures could be away from the primary site of injury. An example would be a tib fib. The primary site of injury may be distally at the ankle. A lot of times there will be a proximal fracture of the tib fib. If the patient's limbs are too long to fit on one IR, you may have to use a second to get that AP or lateral view. Always include a joint. For upper and lower limb follow-up exams, always include a minimum of one joint nearest the site of injury. The joint nearest the fracture should always be included. Horizontal beam lateral. Trauma patients arrive supine position. Cross-table lateral projections are commonly required for the lateral projections. Care must be taken to ensure that the divergent X-ray beam does not project the body part off the IR. With a questionable spinal injury, the head and neck cannot be moved or elevated. Positioning for trauma. Refer to BONTRAGER'S for all your positioning. Views in trauma. Chapter 15 in your BONTRAGER'S. AP chest, an abdomen, a KUB, an uppers, lowers, pelvis, hip, C-spine, T-spine, L-spine, skull, and facial bones. We are not limiting to just these. We will go over more in detail. Chest and abdomen. AP chest, 14 by 17 crosswise. Depending on the patient, you may need to use lengthwise. A grid is required. SID minimum of 40, but 72 is obviously preferred. Shield your gonads. Breathing on second full inspiration. Collimate side to side, all four sides if possible. The patient will be supine if the condition allows them semi-erect or erect whenever humanly possible. Ensure no rotation in the AP position. Central ray 3 to 4 inches below the jugular notch at the level of T7. On occasion, AP lateral to cube may be ordered if the erect isn't possible for air fluid levels. Abdomen. A 14 by 17 lengthwise or 2 crosswise. A grid is preferred. SID 40 inches. Shield the gonads. Breathing is expiration. Patient supine. Ensure no rotation. True AP. The level of the iliac crest and mid-sagittal plane. On occasion, lateral to cube or dorsal to cube may be required for air fluid level. Upper extremities. Hand, PA and cross-table lateral. The IR will be 10 by 12 lengthwise, non-grid, screen, or tabletop. SID is 40 inches. The gonads you need to shield. Collimate all four sides. PA, patient's hand is pronated with palmar surface on IR. AP, trauma. If no other choice, then perform AP. Remember to orient your image properly for a proper anatomical position. CR is perpendicular to the third MCP joint. Lateral. The CR is perpendicular to the second metacarpal phalangeal joint. Cross table lateral, horizontal beam to the second MCP. Wrist, PA, and cross table lateral. 10 by 12 lengthwise, non-grid, screen, tabletop. 40-inch SID, shield the gonads, collimate all four sides. PA or AP, the patient arm is pronated for the PA. For trauma, if no other choice, then perform AP. Remember to orient your image properly for proper anatomical position. The CR is mid-carpal area. A lateral, cross table lateral. Patient is in true lateral, lateral medially. The CR is perpendicular or horizontal to the mid-carpal area. Forearm, AP, and cross table lateral. 14 by 17 lengthwise, 40-inch SID. You shield the gonads, collimate all four sides. AP or PA. AP is preferred. Trauma, if no other choice, then perform PA. Remember to orient your image properly for anatomical position. Central ray would be mid-forearm. If you're performing PA, you may have to do a second image towards the elbow where the radius and ulna will cross. Lateral, cross table lateral. Central ray is perpendicular to mid-forearm, horizontal beam to mid-forearm. Note you may need to perform a separate elbow as well. Elbow, AP, and lateral. 10 by 12 lengthwise, non-grid, screen, tabletop. 40-inch SID, shield the gonads, collimate all four sides. AP or PA. AP is preferred. However, trauma, if no other choice, then perform PA. Remember to orient your image properly for proper anatomical position. The CR is perpendicular to the mid-elbow joint or horizontal beam. Lateral, cross table lateral. Flex elbow at 90 degrees with the thumb up if at all possible. Your central ray will be perpendicular 1.5 inches medial to the mid-elbow joint. Possible horizontal beam may be needed to be angled to patient and IR. HUMERUS, AP and transthoracic lateral. 14 by 17 lengthwise, non-grid, screen, tabletop. 40-inch SID, shield gonads, collimate all four sides. For the AP, abduct the arm slightly and supinate the hand if possible. Central ray is to mid-humerus. For your transthoracic, 14 by 17 lengthwise and a grid. Orthostatic breathing is preferred. Place the affected arm closest to the IR and raise the opposite arm above the head. A central ray is perpendicular, horizontal, through the mid-thorax to the mid-humerus. Shoulder, AP, neutral, and transthoracic. SID is 40 inches, shield gonads, collimate all four sides. For the AP, a 10 by 12 crosswise grid, suspend respiration. Patient is supine in neutral position. Central ray is perpendicular to mid-scapulohumeral joint. For the transthoracic, it's 10 by 12 lengthwise using a grid. Orthostatic breathing is preferred. Place the affected arm closest to the IR and raise the opposite arm above the head. The central ray is perpendicular horizontal through the mid-thorax to the surgical neck for shoulder. Lower extremities. Foot, AP, and cross table lateral. 10 by 12 lengthwise, non-grid, screen, tabletop, 40-inch SID, shield gonads, collimate all four sides. The AP, patient is supine. The central ray is perpendicular to the IR. Then angle 10 degrees posteriorly to the base of the third metatarsal. The lateral or cross table lateral, perpendicular to the IR at the medial cuneiform for mediolateral laterals. Lateral, medial lateral, the cross table lateral center to the level of the base of the third metatarsal. Ankle, AP, and cross table lateral. 10 by 12 lengthwise, non-grid, screen, tabletop. 40-inch SID, shield gonads, collimate all four sides. AP, patient supine, may need to angle the IR to get a true AP. Do not force dorsiflexion. Central ray is perpendicular midway between the malleoli. lateral or cross table lateral. May need to angle to get true lateral. Central ray is perpendicular to medial malleolus for the medial lateral, or horizontal to the lateral malleolus for the lateral medial lateral. Lowered leg, tip fib, AP, and cross table lateral. 14 by 17 lengthwise, nod grid, screen, tabletop, 40-inch SID, shield your gonads, collimate all four sides. If possible, at least collimate two sides. AP, patient is in true AP, may need to be angled to IR or raise the SID to fit all of the tip fib on the IR. Central ray is perpendicular to mid tip fib, or you may have to do this in two parts. Lateral or cross table lateral, CR is perpendicular to IR, mid tib fib. If the limb is too long, one with a larger IR for the site of injury on a separate 10 by 12 with the furthest away from the site of injury. A knee, AP, and cross table lateral, 10 by 12, lengthwise, non-grid, screen, tabletop, and grid. SID 40 inches, shield gonads, collimate all four sides. AP, patient supine. Central ray is perpendicular to IR, parallel to articular facets at a ½ inch below the apex of the patella. Lateral or cross table lateral. Place knee in true lateral, flex knee 20 to 30 degrees if possible. Central ray is 5 to 7 degrees to 1 inch distal medial epicondyle for medial lateral. Horizontal beam for lateral medial lateral. Center 1 inch distal to the lateral epicondyle. Femur, AP proximal, 14 by 17 lengthwise or 10 by 12 lengthwise if two parts of the femur unaffected joint use the smaller IR. Grid, 40-inch SID, shield your gonads, collimate all four sides if possible, if not, at least side to side. Patient is supine, true AP, rotate foot 15 to 20 degrees immediately if the patient can move. If the patient cannot, you do not do this. Top of the IR, placed at the top of the ASIS. Central ray, perpendicular to the femur and IR, midpoint IR. Femur, AP distal, 14 by 17 lengthwise or the 10 by 12, the opposite of the proximal. Grid, SID 40, shield gonads, collimate all four sides, if not at least two sides, side to side. Patient is supine, AP, rotate foot 5 degrees immediately if the patient can move. If not, you leave it alone. IR placed 2 inches below the knee joint. Central ray is perpendicular to the femur and IR, midpoint of IR. Femur, cross table lateral distal, 14 by 17 lengthwise, grid, 40-inch SID, shield gonads, collimate all four sides, if not at least two front to back. Patient is supine, true AP if the patient can move. IR placed 2 inches below the knee joint, place support under the distal leg. CR is perpendicular to the femur and IR, midpoint IR. For trauma, it'll be a horizontal beam. Pelvis, 14 by 17 crosswise, a grid, 40-inch SID, shield gonads if possible. Collimate all four sides. Patient AP, ensure no rotation. Rotate leg medially 15 to 20 degrees if possible. If not, only turn the unaffected leg in. Central ray, perpendicular 2 inches below the ASIS and mid-sagittal plane. Hip, OR lateral, 10 by 12 lengthwise grid, 40-inch SID, shield gonads, collimate all four sides, if not at least front to back. Patient supine, unable to move, affected leg. Place IR at crest crease. Find the angle of the femoral neck to obtain how much to angle the IR. You will want to match the tube to this angle as well. Raise the unaffected leg out of the field. The central ray is a horizontal beam perpendicular to the IR and the femoral neck. This is called the Danielius-Miller method. You will not perform this in trauma rounds. Hip, CLEMENTS-NAKAYAMA modified AXIO-LATERAL. The IR is 10 by 12 crosswise, grid, 40-inch SID, shield gonads, collimate all four sides, at least front to back. Supine, place IR in grid parallel to the femoral neck. Also tilt the cassette back 15 degrees. CR will be mediolaterally as needed so that it's perpendicular to and centered to the femoral neck. It should be angled posteriorly 15 to 20 degrees from horizontal. Pelvis inlet, IR, 14 by 17 crosswise grid, 40-inch SID, shield gonads, collimate all four sides if possible. Patient supine, ensure no rotation. Central ray angle is 40 degrees caudal at the level of the ASIS. Pelvis outlet, IR is 14 by 17 crosswise grid, 40-inch SID, shield gonads, collimate all four sides if possible. Patient supine, ensure no rotation. Central ray, for males, you'll angle 20 to 35 degrees, and females, you'll angle 30 to 45 degrees, cephalic, 1 to 2 inches distal to the superior border of the symphysis pubis. Pelvis inlet and outlet are not on your trauma labs at this time. Perform both obliques for comparison, both centered to the upside or the downside. It depends on your facility's choice. IR, 14 by 17 crosswise, a grid. SID is 40 inches, shield gonads, collimate all four sides if possible. Patient is supine and oblique to the 45 degree with the OK or help from ortho. Central ray, if the downside is of interest, perpendicular and 2 inches distal and 2 inches medial to the downside ASIS. If the upside is of interest, then it's perpendicular, 2 inches directly distal to the upside ASIS. Spine and thorax. Cervical spine, cross-table lateral. Clinical indications, fractures, dislocations, and subluxations due to trauma. SID is 60 to 72 inches. The IR size is 10 by 12 lengthwise. A grid is preferred. Suspend breathing on full expiration. Shield gonads. Collimate anterior and posteriorly to include all anatomy of the spine. Patient is in supine, on stretcher or a table. Maybe with or without backboard, arms at sides if possible. Have the patient relax to depress the shoulders. Place the IR in a grid holder if possible next to the patient supine. Central ray, horizontal beam directed at C4 and the spine. Cervical spine swimmers. Clinical indications, fractures, dislocations, and subluxations due to trauma. SID 60 to 72 inches. IR size is 10 by 12 lengthwise grid. Suspend on full expiration. Shield your gonads, anterior and posterior collimate to include all spine anatomy. Patient is supine on a stretcher or table, maybe with or without a backboard. Elevate arm and shoulder closest to the IR and depress the opposite shoulder as much as possible. No opposites are allowed. Central ray is horizontal beam centered to C7, T1. Note a 5-degree caudal angle may be required if the patient can't depress the shoulder. See spine AP axial. Nothing changes from your normal except for they are supine. So SID is 40, 10 by 12 lengthwise, grid, suspend respiration, shield gonads, collimate laterally. Patient supine, ensure no rotation. Your central ray angle is still going to be 15 to 20 degrees valid at C4. Cervical spine, odontoid. Nothing will change from our normal routine except for they are laying supine. SID is 40 inches. IR is 10 by 12 lengthwise. It's used as a grid. Suspend respiration. Shield the gonads. Collimate all four sides to at least a 5 by 5 square. Patient is supine. Ensure no rotation for trauma patients. You may need to angle so the lower margin of the incisors to the base of the skull are perpendicular. Mouth wide open. CR is perpendicular to IR and open mouth. Cervical spine obliques. 10 by 12 IR, crosswise, screen, and tabletop. 60-inch SID. Your technique will be 70 at 5 MAS. Patient position is supine. Place the top of the IR at the level of the EAM, but off-centered to one side. The central ray will be 45-degree lateral medial angulation with a 15-degree cephalic angle. CR to the level of C4 and the spine. Cervical spine fuchs. To demonstrate the superior portion of the dens when not visualized on the AP odontoid view. Clinical indication, pathology involving the dens and C1 ring. IR is an 8 by 10 grid, 40-inch SID. Shield gonads, suspend breathing, tightly collimate to a 4 by 4 square. Elevate the patient's chin by bringing the MML perpendicular to the table. For trauma patients, you may need to angle more since the patient cannot move their head back. Ensure no rotation side to side. Central ray parallel to MML directed to the inferior tip of the mandible. Thoracic spine, AP and ladder, cross table lateral. AP, 14 by 17 lengthwise grid, 40-inch SID, shield gonads, breathing is on suspended expiration, collimate side to side. Patient supine, ensure no rotation. Central ray is to the IR at T7, 3 to 4 inches below the jugular notch. Your lateral cross table lateral is 14 by 17 lengthwise, a grid, 40-inch SID. You still will shield the gonads, suspend the respiration on expiration, collimate side to side, or well, front to back in this case. Central ray is perpendicular to the long axis of the spine at T7. Lumbar spine, AP and cross table lateral. AP 14 by 17 lengthwise grid, SID 40 inches, shield gonads, breathing suspended on expiration, collimate side to side. Patient is supine, ensure no rotation. CR is perpendicular to the IR at the level of the iliac crest. Cross table lateral, lower lateral. IR is 14 by 17 lengthwise, still using a grid, 40-inch SID, shield those gonads, suspend on expiration, collimate front to back. Patient supine, ensure no rotation, perpendicular to the IR and the level of the iliac crest. Sternum, cross table lateral. IR 14 by 17 grid, 60 to 72. 72 is preferred, and you guys should be using 72. Shield gonads, suspend on inspiration. All sides should be collimated. Patient supine with arms down by side or up over his patient's head to ensure no rotation. CR is perpendicular to the IR center of the sternum. Sternum, LPO. IR is 10 by 12 crosswise with a grid. SID is 40-inch, shield the gonads, breathing, suspend on inspiration, collimate all 4 sides. Patient is supine, ensure no rotation. Central ray is angle 15 to 20 degrees mediolateral to mid-sternum. Angle from right to left across the patient's body. Note the grid must be placed crosswise under the patient to prevent grid cutoff. Ribs. IR is 14 by 17 lengthwise grid, an SID of 40 inches. Above the diaphragm, breathing is inspiration. The CR is 34 inches below the jugular notch as for AP chest x-ray. AP below the diaphragm, breathing is on expiration. The CR is the bottom of the IR at the crest. The AP obliques, 14 by 17 crosswise grid, SID 40 inches. Central ray angle medial laterally 30 to 40 degrees towards the outer edge of the body, centered to include the region of the injury. Headwork, skull, cross table lateral. IR is 10 by 12 crosswise grid, 40-inch SID, shield gonads, breathing, suspend respiration, collimate all 4 sides if possible. Patient supine, ensure no rotation. Central ray is perpendicular to the IR, 2 inches superior to the EAM. Remember, lateral skull routine requires bilateral laterals. Place the IR vertically to the lateral aspect of the cranium. Skull, reverse CALDWELL 15. The 10 by 12 lengthwise grid, 40-inch SID, shield gonads, suspend respiration, collimate all 4 sides. Supine, the patient is supine. CR angle 15 degrees cephalic to the OML at the nasion. To accomplish this, first find the OML on the patient, then angle the CR 15 degrees cephalic to the patient's OML, which will result in an appearance of the CR close to perpendicular beam relationship to the patient and the IR. AP axial 30 degrees TOWNE method. IR is 10 by 12 lengthwise grid, 40-inch SID. Shield gonads, suspend respiration, collimate all 4 sides. Patient is supine, ensure no rotation. CR angle 30 degrees caudate to the OML, or 37 degrees caudate to the IOML, so around 2.5 inches above the glabella to pass through the foramen magnum. Facial bones, cross table lateral. IR is 10 by 12 grid. SID is 40 inches, shield gonads, suspend respiration, collimate all 4 sides. Patient is supine. Central ray perpendicular to the IR midway between the EAM and the outer canthus. Place the IR as close to the patient's cheek as possible. Facial bones, reverse waters. IR is 10 by 12, lengthwise grid, 40-inch SID, shield gonads, breathing, suspend respiration, collimate all four sides. Patient is supine. Central rays parallel to the MML entering at the acanthon. Facial bones, reverse 30. IR is 10 by 12, lengthwise grid, SID is 40 inches, shield gonads, suspend breathing, all four sides should be collimated. Patient is supine. Angle CR 30 degrees cephalic to the OML to the nasion. To accomplish this, find the OML in the patient, then angle the CR 30 degrees cephalic to the patient's OML. This will result in an appearance of the CR close to a perpendicular beam relationship to the patient and the IR. Nasal bones, cross-stable laterals. IR is 8 by 10, crosswise, non-grid screen. 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Supine patient. Central ray is a horizontal beam a ½ inch inferior to the nasion. Nasal bones, reverse waters. The IR is 10 by 12 lengthwise, grid, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Patient is supine. Central ray is parallel to the MML entering at the acanthon. Mandible, AP axial. 10 by 12 lengthwise, grid, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. The patient is supine. Angle your 35 degrees to the OML and or 42 degrees to IOML. Caudal to enter at the level of the glabella. Mandible, AP0, 10 by 12 lengthwise, grid, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Patient is supine. The OML is perpendicular, or you may need to angle to make it perpendicular. The central ray is perpendicular to the IR to enter at the lip. Mandible, AXIO-LATERAL laterals. This will be bilateral. IR, 10 by 12, crosswise, non-grid, screen, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Your central ray will be 25 to 30 degrees cephalic and 5 degrees posteriorly towards the floor. Center 2 inches inferior to the angle of the mandible on the side away from the IR. Zygomatic arches, AP axial. IR is 10 by 12, lengthwise, use a grid, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Patient is supine, ensure no rotation. CR, angle 30 degrees, cauda to OML, or 37 degrees, cauda to the IOML. Center 1 inch above the glabella to pass through the level of the mid-arches. Zygomatic arches, reverse waters. 10 by 12, lengthwise grid, 40-inch SID, shield gonads, suspend respiration, collimate all four sides. Patient is supine. Central ray is parallel to the MML, entering at the canthon. Zygomatic arches, SMV. IR is 10 by 12, crosswise, non-grid screen, 40-inch SID, shield gonads, respiration is suspended. Collimate all four sides. Patient is supine. Central ray, perpendicular IOML, should be angled to maintain the CR-IR perpendicular midway between the zygomatic arches, 1½ inches inferior to the mandibular symphysis. Do not recommend this for trauma patients. You will need to angle more than you will need to move their head. The end.